Today we're going to review how to place a subclavian central venous catheter using ultrasound guidance. This video is primarily to review how to follow the anatomy of the subclavian and axillary veins with the ultrasound. We will discuss key points regarding central line placement, but for a complete review of how to place a central venous catheter, please refer to more detailed resources in the text of this video. The first part of this procedure involves gathering all of your supplies. Standard central line kits should have the majority of the supplies you'll need, and at Temple, the rest of the supplies should be in the central line setup kit, including a full-body drape, gowns, and most importantly, a sterile ultrasound probe cover and sterile gel. We'll be using the vascular probe for this procedure. Prior to getting sterile and cleaning the skin, evaluate the anatomy of your patient on both sides to see which side looks like it will be easier to place your line. If both sides look equally accessible, the left subclavian is preferred as it has a more direct route to the SVC. This video will demonstrate the landmarks as seen from the left side of the patient. This procedure can be done in either the transverse or longitudinal plane of the ultrasound probe, and each has its pros and cons. Most of us are more comfortable with the transverse approach because we use it more frequently when placing ultrasound-guided IVs. Longitudinal provides a better framework to assure that your needle has not punctured the back wall of the vessel. However, it can be more technically difficult to keep the needle in the exact plane of the probe, and many of us are just less comfortable with this approach. This video will demonstrate the transverse approach. As a refresher, the axillary vein becomes a subclavian vein as it passes the lateral border of the first rib. The main difference between placing a blind and ultrasound-guided subclavian will be the starting point of your needle insertion. When placing a blind subclavian, you start just lateral to the bend in the clavicle and aim towards the sternal notch. When placing an ultrasound-guided subclavian, we'll start at a more lateral location in the axillary vein to give us space to follow the needle through the soft tissue before our view is obstructed by the clavicle. To find this position, you can start at the lateral border of the clavicle and follow the subclavian vein further lateral until you have identified a good starting point in the axillary vein. After you have followed the subclavian laterally to a point that is the axillary vein, you can confirm that the vessel you followed is venous by pressing down with the probe to collapse the vein. Alternatively, you can place color on the vessels and look for pulsatile flow in the artery. Now let's take note of some of the anatomical structures you'll see when placing this line. The vein is adjacent to the artery, which is normally slightly cephalad in this lateral location. Deep to the vein and artery, you'll see the pleural line, which will be an echogenic structure on the screen. Beneath that, you'll see dark space, which is the lung tissue. One important note about the anatomy you will see on the screen. When using ultrasound, convention dictates that you stand on the right side of the patient and always hold the probe marker towards the patient's right, which will be your left, or towards the patient's head. This ensures that the left side of the screen is on your left, and the probe marker should also be on the left side of the screen. If you are placing the catheter in the right axillary vein, you should hold the probe conventionally with the probe marker pointed towards the patient's head. However, if you are placing the line from the left side, in order to keep the left side of the screen on your left, you should actually point the probe marker towards the patient's feet. All anatomy you see in these clips are from the left side of the patient with the probe marker facing towards the patient's feet. You can rotate the probe 90 degrees to identify the vessel in the longitudinal plane as well as get a feel for its course as it approaches the clavicle. Once you have identified your point of entry at the axillary vein, you're ready to start placing your line. Place a wheel of lidocaine at the site you plan to enter the skin with your needle. Line up the axillary vein with the mark in the middle of the probe marker. Pull back on the plunger of the syringe as you enter the skin. Find the tip of your needle in the soft tissue and slowly advance your probe until the needle tip falls out of the screen. Hold your probe still at this point, then advance your needle tip back into the screen in plane with the probe. Do this until you break through the wall of the vein and see your needle tip in the lumen. At this point, you should see flash in the syringe. Drop the probe at this point, disconnect the syringe, and thread the wire through the needle into the vessel. If you hit resistance at any point, you should withdraw the wire and place the probe back on the patient to verify that the tip of the needle is still in the lumen of the vein. After threading the wire successfully, remove the needle and place the probe back on the patient in the longitudinal plane and look at the wire crossing the soft tissues into the vessel. You should be able to see that the wire is in the lumen and has not punctured the back wall of the vessel and ended up in the soft tissues, the artery, or punctured the lung. This should become an important step in any ultrasound-guided line, not just a subclavian. Make sure that you're checking for wire verification before you move on with the rest of your line. After you verify that the wire is still in the lumen of the vessel, you can move on with the rest of the steps in central line placement. And that's it! You've successfully placed your ultrasound-guided subclavian line. Thank you so much for watching. Please feel free to email with any questions and check out our other resources for ultrasound-guided procedures on our website.